Good afternoon, and welcome to today's presentation, 2019 QPP-MIPS Cost Performance Category. Excuse me. My name is Valencia Harper, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our Health Visions Delmarva PTN YouTube channel. You may find the link on the flyer included in the invite to today's webinar. We always start our webinars off with a review of our learning objectives. Today, we are going to learn various ways that we can take advantage of this 2019 QPP-MIPS Cost Performance category. We are privileged to have with us Cindy Eiseman, Project Manager, and Barbara Vugrinec. Cindy is Project Manager for Health Visions Delmarva, a practice transformation network working through the CMS Transformation Clinical Practice Initiative. Cindy has over 30 years of experience in healthcare, starting in the area of health information management and expanding her skills in areas of expertise to performance improvement, operations management, healthcare financing, and practice transformation. Cindy has been a CEO, COO, and Regional Quality and Operations Director with Health South, Kindred, and several community hospitals. Cindy is a native of Pittsburgh and graduate of the University of Pittsburgh and the Troy University in Alabama. Barbara's entire career has been in healthcare. She began her career in the hospital environment with over 20 years of experience in information systems, health information management, decision support systems, patient access, and patient business services. She was a Chief Information Officer, Vice President for over 10 years at BB Hospital in Lewis, Delaware. Over the past 4 years, Barbara has worked in assisting physician offices with their EHRs, business, and transformation process. She worked as a project coordinator and practice transformation specialist at Quality Insights of Delaware. Barbara is currently employed as a practice advisor at Health Visions Delmarva. Barbara practiced as a board member for Delaware Health Information Network for 5 years. She has her Master's of Business Administration, and she is passionate about improving healthcare and patient outcomes. I would now like to hand it over to Cindy to begin our presentation.
Hi, everybody, and hopefully we're seeing my screen now. So welcome, everyone. It's actually been a little while since we have had a webinar. So I welcome you all back, and I'm glad that you could join us. And of course, we always have great attendance for our MIPS webinars because they're the most nuts and bolts things I think that we deal with. Our questions to run on today are 3. What are the cost measures for the QPP-MIPS for the 2019 performance period, and which ones apply to me? How will the cost measures impact my 2019 QPP-MIPS performance score, and how can I impact my performance on those cost measures? First, for what's new in 2019. The wave of cost measures is increasing to 15% of the total MIPS score, so that's up 5% from the year just ended. We do continue to have the 2 measures that you had last year, the total per capita cost and the Medicare spending per beneficiary measures, and those do remain the same in their definition and application. There will be, however, 8 new episode-based cost measures, and you have a case minimum of 10 for procedural episodes and 20 for acute inpatient medical condition episodes. And we're going to learn more about those different episodes in the second half of the presentation today. There's also a new option to use facility-based scoring for facility-based clinicians if you participate as a group in MIPS in 2019. This option doesn't require any data submission, and it's expected that they will release a facility-based scoring preview in Q1 of 2019. For facility-based scoring, the measure set for fiscal year 2020 of the hospital value-based purchasing system will be used for the QPP measurement performance period. And I do just want to take a minute to talk about facility-based scoring, even though it's not your cost scores that would be impacted by the facility-based scoring. It's actually your quality scores. Facility-based scoring, we'll look at it in three ways: eligibility, attribution, and election. And so who's eligible for facility-based scoring? If you are a provider that furnishes 75% or more of your services in the inpatient setting. An inpatient setting means a point of service of 21 for inpatient hospital, 22 for an on-campus outpatient hospital, or 23 for an emergency room. Hospitalists and emergency physicians, as well as anesthesiologists who work in the hospital, frequently fall into this category. You have to have at least a single service billed with the point of service code for inpatient hospital or emergency room. So it can't all be on-campus outpatient hospital. And a group would be considered facility-based if 75% or more of their eligible NPIs were eligible. Attribution, how do they actually attribute patients? Well, a facility-based clinician is attributed to the hospital at which they provide services to the most Medicare patients. So if you are a hospitalist who is a contract hospitalist and you're at multiple hospitals, the one where you provide the most services to Medicare patients is the one you would be attributed to, and the one whose data would be reported for you. A facility-based group is attributed to the hospital at which the plurality of their clinicians are attributed. So we look at it at the clinician level, and then that determines where the group is attributed. If there's an equal number of Medicare beneficiaries treated at more than one facility, the value-based purchasing score for the highest scoring facility is used. So you always get, by default, the highest score possible. And if they're unable to identify a facility with a hospital value-based program score to attribute your performance to, then you would not be eligible for facility-based scoring. So you have to be in a hospital that is contributing data and contributing adequate data. So that's eligibility and attribution, and the last thing is election. So an election, that is, how do you decide whether you want to use your facility-based score or not? And in a way, this is kind of an automatic thing. Facility-based measurement will automatically be applied to any MIPS eligible clinician and group who are eligible for facility-based measurement. So if you're eligible and get cases attributed, they will calculate what your quality and cost score would be with the facility-based measurement. There's no data submission required for the quality and cost categories for facility-based. The facility-based measurement happens by itself. And an individual group does have to submit data on improvement activities and promoting interoperability in order to be measured under this measure. Now, remember though, the thing is, even though they're going to calculate this for you automatically, if you actually still submit your own quality and, well, not cost data because that's automatically calculated, but if you still submit your own quality data and that gives you a higher score than the facility-based data, you will get the score of the higher-based performance. So it can never hurt you. It can only help you. And I don't think it's something you need to worry about. It's going to happen in the background. We still recommend that all practices submit their quality data as a practice independently, even if they are eligible for facility-based data. Okay. So now we have a polling question, and it's a general question. So Valencia, you want to launch that one?
Sure. And our first question is, has your practice developed any strategies to lower healthcare costs? Our practice has analyzed our cost data and reduced costs. Our practice does not know where to start to reduce costs. Our practice has not considered strategies to reduce costs. So we're collecting those responses. It looks like we have 78% of practices have analyzed their cost data and reduced costs. 18%, our practice does not know where to start to reduce costs. And 9%, our practice has not considered strategies to reduce costs.
Thanks, Valencia. I have to say, it kind of warms my heart to see 78% say that you're doing something to reduce costs. So yay, we have had success in our 4 years of grant work here. That's an important thing to be thinking about as we go through this, because no matter what and how and which scores impact your score of the cost scores, you do have to be thinking about how you as a practice individually are working to be the most cost-effective practice that you can. So let's talk about calculating the cost score. Your cost achievement points divided by total available points equals your cost performance score. So it can't ever exceed 100. You collect your points, you divide it by total available points. The highest score that you can get is 100%. You only get rewarded based on that percentage. There's no added improvement reimbursement or improvement award, if you will. The Bipartisan Budget Act of 2018 delayed the consideration of improvement in cost performance score until 2024. So each year, your cost score will get calculated, but it really stands by itself. It really doesn't matter if it's better or worse than the previous year. You simply accrue points based on that score. Medicare will not calculate a cost performance category score if the eligible clinicians aren't attributed any cost measures because the minimum number of cases hasn't been met. Those of you who have looked at your current 2018 benchmark reports, the preliminary benchmark reports, you can see that a cost score is calculated, or it tells you you don't have a cost score because you didn't have enough cases in any of the categories. That report is a pretty good benchmark or starting point, baseline starting point for where you are right now to give you an idea of where you might end up in 2019. And then if a cost performance category score can't be calculated, the 15% is reweighted to the quality category. And that is the default place where everything gets reweighted if you can't actually score it. If you have, you're exempt, for example, for promoting interoperability, those points get moved over to quality. So it is always important that you are performing at your best on your quality measures. So the first measure is Medicare spending per beneficiary. And I'll go relatively quickly through these first two because they aren't any different than last year. Medicare spending per beneficiary assesses total Medicare Part A and B costs that are incurred by a single beneficiary immediately prior to, during, and then 30 days following a qualifying inpatient hospital stay. And then it compares these observed costs to expected costs, and it determines what percentile or decile, I guess, of spending that you're in. Expected costs of an episode are based on the clinical condition or procedure that triggered the episode, as well as other factors that may influence costs but aren't directly related to patient care. One of those factors is that they do adjust it for specialty, although I have to say we haven't been terribly impressed with how well that works. But your specialty should inform, at least to some extent, the other providers you're being compared to. This is how it works. So you see that the box at the bottom that says the admission triggers the episode. So an admission has to happen. Once the admission occurs, they look back 3 days at everything that was billed and everyone who billed during those 3 days, and then they look forward through the index admission, the actual admission that occurred, to discharge, and then 30 days passed, which marks the end of the episode, and they're looking at all charges that come into Medicare from all providers who treat the patient. So there's an admission that triggers this, and if you see, treat, bill for that patient from 3 days before until 30 days after, that episode will get attributed to you. Each episode is attributed to the TIN NPI responsible for the plurality of Part B services during the index admission. Part B services are defined as all clinical services billed on non-institutional claims. So it's the provider's actual charges that determine who it's going to get attributed to. So it's going to the TIN NPI combination, the tax ID number and provider, who was responsible for the plurality, the most of those services. To determine attribution, Part B services billed by the MIPS eligible clinicians are considered, if they are, on the admission date in a hospital setting, so inpatient, outpatient, ED, during the stay, regardless of the service, and then on the discharge date with the place of service restricted to the inpatient hospital. So if you had an outpatient visit on the discharge date, that wouldn't count. The minimum case volume for this measure is 35, meaning 35 Medicare spending per beneficiary episodes have to be attributed to an eligible clinician or group, a little excess 9 there, for the measure to be scored. Sorry about that. So 35 is your bottom line. You would need to have provided the plurality of care to at least 35 patients, Part A, Part B, straight Medicare fee-for-service patients for this to kick in. And then the measure is risk-adjusted to account for beneficiary age, illness, and severity. So remember, 35 at least. So what can you do about this score? Remember, all the cost scores, you aren't submitting the data, you're billing, and then they're taking your billing data and they're calculating it for you. So what could you possibly do to impact it? It's a little hard, these measures, because you don't get constant, actionable, as-we-go data. You can't look it up on a dashboard in your EHR and say, hey, we're doing well, or we're not. But there are some certain practices that you can do that can help you with this. First of all, partner with your hospitals to design efficient processes. If your hospitals have a focus this year on congestive heart failure and COPD or sepsis or whatever they pick, partner with them. They're looking for partners to help them to reduce those costs. So anything that you can do to get involved in those projects. In the state of Maryland, there are hospital-based incentive programs that the hospitals benefit from that they can engage providers in and offer them shared savings on those initiatives. So by all means, if you're in Maryland, talk with your hospitals. If you are seeing a lot of inpatients, about any cost improvement programs that they are working on with the HSCRC. Thoughtfully manage your length of stay. You know, that's the age-old one, right? Everybody's always focused on length of stay, but that is important. And when we say thoughtfully, we do mean that, because it isn't worth cutting a day if that means the patient's coming back in a week. So if keeping that patient one more day will keep them out of the hospital permanently afterwards, you know, for at least 30 days, that day is probably worth the penalty that you would pay bringing that patient back in. So you do want to be thoughtfully managing length of stay, managing to the average, yet always taking into account what's the specific situation of this patient. Utilize pre-admission education and patient engagement activities to ensure a smooth process for elective admissions. Orthopedic surgeons have pioneered in this area. They have joint camp, and if you're going to come in and have your knee replaced, you have to go to pre-procedure education at the practice where they walk you through what to expect. They start you with pre-procedure exercises. Anytime you can do that for elective type admissions, that is going to help you save costs. You're going to have better outcomes for your patients, and you're going to reduce readmissions. Access inpatient care management and discharge planning resources. Many of the hospitals in the area have care coordination resources that can help you with discharge planning and can help to ensure that your patients get post-discharge services set up appropriately. But frequently you have to order them. They're not automatic. So look at your hospital that you practice at. If you're going to have inpatient costs attributed to you, talk to your care coordination department, understand their processes, understand how to order those services, so that you get your discharge planning started right at admission and it goes smoothly at the time of discharge. Educate the patient about his or her diagnosis throughout the stay and engage the family in the support network. So much of the thing that increased costs in these stays isn't what happens during the stay, because a lot of that is standardized, but it's what happens afterwards. Do they get the follow-up care they need? Are they following their follow-up plan? Are they equipped and do they understand their follow-up plan? So it's important to engage the family and the support network to make sure you get the best outcome and therefore aren't accruing additional costs in those 30 days after the stay. And then order consultations thoughtfully. Will the consult help to move the patient to discharge, or is it more appropriate for the post-discharge setting? So if you need to consult infection control because you have a serious thing going on there, by all means, let's do that so we get the right treatment started. But if you find a another diagnosis that is not related to the reason that the patient is in the hospital, and it's safe, it's not something that needs to be taken care of right away, think about that. Only order consultations that are appropriate to the stay that they're in. In addition, you need to use post-discharge best practices. So make appointments for clinician follow-up within 7 days of discharge, and do that prior to discharge. If you are practicing in the community and you're the person that is both attending the patient and you're going to be the person doing the follow-up, have a system in place between your office and the hospital that you get those appointments scheduled prior to the patient leaving. Don't wait for them the day they leave to have that on their discharge instructions and say, call us and get an appointment. Make sure you get those scheduled. Schedule to organize test results and follow up appropriate discharge testing and services prior to discharge. If it needs to be scheduled, have it happen prior to discharge. Engage your care coordination staff in helping you with those things. Give the patient a written discharge plan, including what to do if a problem arises, and assess their understanding. Using teach-back is just vitally important at all levels of interaction with the patient. That's the provider, and that's their advanced practitioners who might be assisting them, and even the office staff. If we use teach-back to make sure that patients understand the plan, we have a much better chance that they will follow it. Expedite transmission of the discharge summary to outpatient providers. So that's really a hospital responsibility. But if you are the person on the receiving end that has to do the follow-up and you are not getting prompt discharge summaries from your hospitals, you need to reach out to them and talk about how you can make that happen more efficiently and more completely. Call to reinforce the discharge plan and offer problem solving 2 to 3 days after discharge. That follow-up inpatient phone call 2 to 3 days after discharge can be a really important touch point to make sure that the patient really did get everything done and in place that they needed. And then assign a risk score for readmission. Identify your high-risk patients and refer them to either transition case management, a transition coach, or in your own practice, if you have a care coordinator, refer them to your chronic care coordinator for some episodic case management. So these are all ways, if you are a provider who has frequent inpatients and you're getting this cost score assigned to you, that you can help to reduce that cost. Okay, the other one, which is actually the one that more of our practices see, right? Medicare spending per beneficiary is a lot of hospitalists, a lot of surgeons, a lot of anesthesia providers. But total per capita cost for attributed beneficiaries is one that'll hit any practice. And that's because it's really an ambulatory type of measure. So what is it? It is a payment standardized, annualized, risk-adjusted, and specialty-adjusted measure. So it is supposed to be taking into account how seriously ill is the patient, what specialty is this patient being attributed to, and it's supposed to standardize payment so that across the country variations geographically and regionally don't impact you. It evaluates the overall cost of care provided to beneficiaries attributed to a clinician as identified by their tax ID number and NPI. So it's always that combination of tax ID number and the NPI number. The total per capita cost for all beneficiaries measured can be reported at the TIN or the NPI level. So this could either be for an individual, if you report individually, or as a group. And if a beneficiary is attributed to a provider group, all Medicare costs, all in capital letters and bold, Medicare costs for that beneficiary are attributed to that provider group. So, how do you get patients attributed to you? The first question, so this is an exercise where CMS goes through it by beneficiary. They don't start with provider. They start with the beneficiary, and they ask the question, did this beneficiary, Mr. Jones, receive primary care services from a PCP, a nurse practitioner, a physician assistant, or certified nurse specialist? And a PCP is either an internal medicine, family medicine, or general medicine practitioner. If you are designated as one of those 3 types of doctors, providers in the PICO system, then, and they saw you, then they are attributed to you. They only have to see you once. That's it. So all you specialists on the line, keep that in mind. If they see a PCP, internal medicine, general medicine, family medicine, a nurse practitioner, PA, or a certified nurse specialist, even once in a year, that patient will be attributed to that provider. If they see more than one of those type of people, the person who saw them the most will get that patient attributed to them. But that's the first bar. So now if the answer is no, we come down the left-hand side. The second question gets answered. Okay, did they receive primary care services from a specialist physician? So anybody else. If anybody else basically charged for an E&M code and they didn't see a PCP even once, then that patient is going to get attributed to that specialist. And if all that patient saw was multiple specialists through the year, it's the specialist who charged the most, who saw the patient the most. If they didn't see anybody, then they don't get attributed to anybody and they go away. But you can see that if you are a specialist, it's possible to have people attributed to you. And your best defense against not having people attributed to you is to make sure your patients have a primary care physician. So let's say you are a primary care physician. We have a few of those within our PTN and on the line. What do you need to do? Because this score really is focused at you and your practice. You have to actively manage your patient panel. You have to risk stratify and use care coordination for your high and emerging risk patients. There's really no way around that initiative. If you are primary care in practice out there, you've got to figure out a way to risk stratify and do some kind of care coordination services. Even if you don't have a nurse to do those, if you can do that with your staff as far as follow-up goes, you need to implement that. You need to educate and to re-educate and to re-educate and to re-educate your patients on the appropriate setting of care to hold on expensive and inefficient ED visits. That may mean that you need to change your office hours too. You might need to have longer office hours. You might need to have Saturday office hours. You might need to have some kind of collaboration with another primary care provider in the community where you back each other up and you share that coverage. But education and re-education on the appropriate use of the ED is extremely important to hold these costs down. You need to establish strong referral communication relationships with specialists used most often and make your referrals thoughtfully to coordinate care. You really need to send them to a specialist. On the other hand, are you waiting until the patient is a train wreck to send them to the specialist? So you need good communication between you and the specialist to really understand what is the optimal time to make that referral. You also don't want your specialist sending people to the ED. So you, again, want good communication about what you can handle, what your hours are, and what you would be able to manage for those patients. You need to implement evidence-based guidelines and best practices and hardwire these protocols into your EHR to ensure implementation. As we talk to practices, they always say we follow the most up-to-date evidence-based guidelines, but very few practices really consistently use standard order sets or protocols. The one advantage of an electronic health record is it can really help you by basically reminding and keeping us on track with what is best practice and making sure those things happen as required and scheduled. Provide patients with alternative routes of communication, patient portal and secure email options, reduce office visits. Sometimes people schedule an office visit because they need to ask a question about something that could have been answered by phone or in an email. That added an office visit. So that can actually help to not only decrease costs, but to improve patient satisfaction and the turnaround time on answers to those questions. And then use your annual wellness visits to develop a holistic plan of care for patients and provide them with written plans. And again, use TeachBack at every level of your practice. Now, specialty providers. I know this is the most unfair measure ever. I was just talking with a practice yesterday, and we said that exact same thing. We know it's unfair. And that practice I was talking to yesterday had only 20 patients. And that's all you need. 20 patients, there's the line. So if you had 20 patients, they're going to calculate this score for you. And that's not a lot of patients. And in some of our specialties that are very high-cost specialties, if you have 20 people attributed to you, and every one of them has, let's say, cancer, or every one of them is on dialysis because you're a nephrologist, you're going to lose on this measure. It's very difficult to manage that. So what do we tell you to do? Ensure that your patients have a PCP. It's the number one thing. Ensure that they have a PCP. And ensuring that they have a PCP doesn't mean that you ask, who's your PCP, when you register them. It's that you ask that, and then you ask, when was the last time you saw them? And if that has been more than 6 to 12 months, you need to offer to make them an appointment for a visit, because they need to get back to their PCP. All they got to do is see them once in the calendar year, and they will be off your ledger. And that's a cynical way to look at it, but it really is also the best thing for the patient. As a specialist, you don't, I'm sure, really want to be managing their sniffles or their hay fever or their, GERD if you're the cardiologist. So you really want to get people back to their PCPs so that their care can be fully managed, holistically. So for specialty practices who are only managing a small segment of the patient's care, it's difficult to manage this overall cost. Ensuring these patients are attributed to a PCP will ensure they're not attributed to you. Okay, other than that, what can you do? Establish strong referral communication relationships with your PCPs, the ones they use most often. Coordinate their care. Have people who you know you can work with, that when a patient doesn't have a PCP, you can make a recommendation, and you know that PCP will work with you to get that patient into their practice and start them in their care. Again, educate and re-educate your patients on the appropriate setting of care. In specialty practice, it's much more frequent to have answering machine messages after hours that start with, if this is a medical emergency, hang up and dial 911. And then to basically not have access for evening hours or weekends. And so what does the answer become? Even if they hold on and go to the answering service, they are directed to urgent care or the ED because the doctor isn't going to be in the office. You really want to not have people going to the ED. You really need to have a solid after-hours communication system with your patients, and the ability to get those people in the morning when they call you after hours, so that you can fit them into your schedule and leave some appointments available for those patients. Implement the evidence-based guidelines, hardwire them, and formalize those protocols, the same as the PCP. We want to always be using best practice. And then finally, provide patients with alternative routes of communication. Don't underestimate the power of the portal. A lot of times a question can be easily answered and you don't need to have an appointment. That's going to help you to control the cost. Okay, so we have our next polling question. Valencia, you want to launch that?
Sure. And the question is, has your practice implemented any MSPB or TPCC initiatives which may impact your cost reduction score? Yes, our practice has fully implemented an initiative. Our practice is in the process of implementing an initiative. We do not know where to start in implementing an initiative. So we're collecting those responses. Just a couple more seconds as we tally those in. Okay, it looks like we're at 18% that says yes, our practice has fully implemented an initiative. 55%, our practice is in the process of implementing an initiative. And 25%, we do not know where to start in implementing an initiative.
Okay. Well, I will say that our practice advisors will definitely be out talking with you about the cost measures and how maybe you can start and the things that might be appropriate to your practice. So for the 25% that need help, we will not abandon you. We have time to work with you still on that one. I will say that 55% having identified something and starting probably points to the fact that there's nothing like that first feedback report that tells you what your cost score was last year, to get you looking at your cost score and knowing that you have to do something about it. So we hope everybody progresses well with that. And again, reach out to your practice advisor if you would like additional help from them in implementing things that might help you to impact those two general scores. So I think next we're going to hand it over to Barb, and she's going to talk to us about the new stuff, which is the episode-based cost measures.
Picture. Okay. Not there anymore. Go to your folder and open it back up. Well, I just put the link in there.
Just a couple seconds and we'll be viewing Barb's screen.
And just watch your Sorry about that, guys. Okay, what I want to do is update you on 8 new episode-based cost measures that is added this year. Not only now do you have Medicare spending per beneficiary cost measure, and the total cost, capital cost for attributed beneficiaries, they are adding 8 more, and we will talk about them. And basically, the 8 more are episode-based cost measures. So it deals with a trigger. A trigger could be an admission, or it deals with some kind of procedure being done. So the episode-based measures specification only includes items and services that are related to that episode of care for the clinical condition or procedure. It really deals with, like for colonoscopy being done, it deals with anything that deals with that particular procedure. These measures are calculated using Medicare Part A and B fee-for-service claims data. Again, you guys don't need to do anything, submit anything. They're going to be looking at claims to calculate the cost measures. Basically, the episode of care are categorized by 2 different ways: procedures, and it's triggered by performance of a major procedure, or an acute inpatient medical condition, triggered by the evaluation and management claims during the hospitalization, with specific DRGs or diagnosis-related groups. Again, I'm just reviewing what we talked about in the beginning. For these specific episodes, you need at least 10 of them for them to allocate the cost to you. So if you're a surgeon and you're always doing colonoscopies, of course you're going to probably hit this group and be able to. They could be looking at your cost measures. The minimum for the acute inpatient condition is 20. So if you have any kind of procedures under that, the cost won't be allocated to you. Each episode group consists of the following components. You have episode triggers and windows, and Cindy talked about that. It's usually 3 days before the procedure or admission, or 30 days thereafter. And again, they're really looking at that spell illness or the procedure, because they want to make sure, 3 days before is if you're going to the hospital, you may have some tests done before. And then basically during the stay, what happened. And 30 days after is, again, they're trying to make sure that if patient is admitted into the hospital, that, that you don't have a readmission after that, so that the patient is well before they leave and you're not discharging them too early. Items and service assignment, basically it looks at every, item that deals with that patient during that episode. There are always exclusions. Sometimes and I'm going to talk to you about where you can get all this information, the detailed information. There's always exclusions that may not be included in that specific episode. How their attribution methodologies, and there's always some risk adjustment variables. Assignment of items and services to episodes. Services and their associated costs are assigned to an episode if they are furnished within the patient's episode window. And again, that's at 3 days before and 30 days thereafter, and are based on clinical determination of whether a service is under the influence of that attribute clinician. Again, assigned services might include diagnostic services, treatments, and ancillary items and services related to the treatment, as well as services following the initial treatment period. So what that's saying is the patient submitted for a specific procedure, and 30 days thereafter has to get another procedure or something else or diagnostic test. That specific test will be assigned to that episode if it's related to that episode. Services furnished as a consequence of care, such as complications, readmission, unplanned care, and emergency department visits, may also be included. Again, I can't stress more that if something goes wrong, I mean, you really want to talk to your patients after a procedure's done. So if a patient is having a colonoscopy, and it would be good for you to actually talk to them the next day to make sure everything's okay, so that there's no problems with going to the emergency room or anything that may be a complication. Or you may want to have a good discharge plan, so you want the patient to know how to get up with a doctor in case something's going on. Procedure episode groups, and again, it's procedure ones are actually triggered by the performance of that major procedure. Usually the doctor that does the procedure is the one who's going where the cost is going to be allocated to. And again, with the coding system, it's identified by the HCPCS or CPT procedure codes. The clinician rendering the services or the organization that clinician is billing under for that service is identified by the information provided in the provider tax number and performing physician field on the Medicare Part B claim. Again, this is real important, so as you're actually looking at your cost data, you want to make sure it's being appropriately billed and that you have the right information in the right fields on the claim. These are basically the episode-based measures this year. And I want to tell you that all these things have been probably studied over the last 3 years. They actually had people volunteer to actually go through this process and see how their costs look and how they could actually look at different ways of reducing costs. So here we have the PCI in an outpatient environment, the knee arthroplasty in an outpatient environment, the revascularization for lower extreme chronic critical limb ischemia, again, the cataract removal. We talked about the colonoscopy procedure with screening and surveillance. And basically, on the inpatient side, there's 8 of them. Intracranial hemorrhage or cerebral infarction, simple pneumonia with hospitalization, and then again the STEMI and PCI, which is again another inpatient procedure. So if you've done any of these or you have any of these diagnoses or codes or procedures, you will find they will be looking at your costs and comparing you with other physician costs. Let's just talk about the screening and surveillance colonoscopy. An example. Basically, I'm not going to get into the details of what's there, but you can go out on QPP, and they have all this information, this detailed information. This is a code list that actually shows in an Excel spreadsheet what they're looking at. They're looking at the trigger codes. So basically, if you want to know whether your colonoscopy got assigned as part of the cost, there's specific CPT codes that they're looking for. For example, they may be looking for a 45370 all the way up to a 45380, and these are different colonoscopies procedure codes. There are also 2G codes that they're looking at. And again, you can take a look at this specific thing out on the QPP website. They also look at, what exclusions. There may be a CPT code you're using today that you think should be included, and it's not included because it's excluded. So that these detailed sheets, again, on QPP are very, very important. So when you go back and look at the list of procedures that are being included this year or inpatient admissions, you need to actually go into QPP and take a look at that. Basically, the two forms that you need to look at is the first one, which is an Excel spreadsheet, and this is the second form. And this really is more in a just a written form, explanation of all the things that they are doing. The first one's more of an Excel spreadsheet. This is just a Word document. So it actually talks about the different triggers, and it defines the episode. And how the episodes are attributed to a clinician. It assigns the costs. It again looks at those that are excluded from those episodes, and then it comes up with the estimated expected cost through risk adjustment, and it calculates the measure score. So basically, this one plus the first is important when you're looking at your data. Here's one that I wanted to talk to you guys about, because these are colonoscopies that were actually in the testing part of this. And it was a company, actually, Digested Health Network, that, I'm going to go through this pretty quick. Digested Health Network, who actually explored these different things and actually tested this particular procedure out. They actually came up with, and I know this is a lot of detail, they actually came up with this detail that looked at it, colonoscopy, and the detail of the charges and things like that, of what was most expensive. And can't really see this at this point, but basically it really shows that in the hospital outpatient where procedures were done, it was more costly than if you did it in an ambulatory surgical center or in a physician's office. So physician's office was the cheaper way of doing it. And then you can see how people were charging. The next one deals with looking at screening versus diagnostics. And this is, I like this, it's 2015 data, but basically you can actually take a look at your colonoscopies and what you're charging and see how it compares to this. And see where you're charging too much, or where things you are charging for you shouldn't be charging or shouldn't be doing. Example of the calculation, calculating the score for 2019 MIPS Cost Measures. Just quickly, any of these, of course, everybody will have a TPCC measure, if you're primary care especially. The MSPB measure basically will be on there if you're eligible for that. Any of these procedures that you do, they're going to be adding them up and coming up. As you can see, you have achievement points available, 10, 10. And if you're doing knee, then basically it will calculate a score based on that. It will then weight it, and you will come up with the total score that you have. Okay, polling question.
Okay. Thank you. This is our final question. How comfortable are you in implementing strategies in your practice to reduce healthcare costs? Very comfortable. My practice needs help with MSPB and TPCC cost measures. We need help with the new episode-based cost measures for both B and C. So just a few seconds while we collect those responses. It looks like we have 22% that feel very comfortable, 11% feel as though their practice needs help, and 67% say both B and C.
Okay. All right, I guess we know what we need to work on.
Thank you, Valencia. And basically, the only thing else at the end of here is if you want to find this information, you go into QPP, access the resource library, and again, look at performance year 2019, and you want to look at MIPS, and you want to look at the cost category, and put in all, and you will see this information showing up. It will show both these sheets for each specific measure, the 2019 cost measures information form, so if you're looking for colonoscopy, and the 2019 cost measure cost list if you're looking for a colonoscopy. So you would have to look at both of these type forms to see how you can drill down into the information.
Okay. So Valencia, you want to give me the screen back, and let's see if we have any questions out there. If you have questions, you can type into the chat box.
And Cindy, it looks as though we do have one question. Okay. What is the best way for a specialist to avoid the cost measure?
Well, so again, that TPCC, that total patient cost of care, get them to a PCP. So that's always the first thing. But I pulled up on the screen a list of another way you can go, and that is to get out of MIPS completely. And so how does one get out of MIPS completely? That would be to participate in an alternative payment model or a value-based payment system. For specialists, probably your track to do that would be available to you would be what's called BPCI Advance. It's a bundled payment system through Medicare. On the screen, what you have listed here are the different episodes that fall under the BPCI Advanced. You need to, in BPCI Advanced, participate with a hospital, usually if it's an inpatient clinical episode. So you would need to find out in your area which bundles your hospitals that you participate with are working on, and then become a partner with them in BPCI. For outpatient clinical episodes, you don't need a hospital, but you would need, if you're working with an ambulatory surgery center or some other freestanding entity, you would need to talk to them about what they're participating in. I think that as you look at this list, you will see that a lot of the episode-based cost measures that Barb just reviewed are also the same topic areas, if you will, that the bundled payments fall under. So it would really be just moving from one system to the next. But this really is probably the best option that specialists have for moving into alternative payment models. With this one, I think the biggest caveat is that it's currently enrolling. So enrollment ends June 24th in the next iteration of this, and that would be for 2020. In 2019, you really can't do anything. You have to have been enrolled in BPCI already. So for 2019, you're going to have to work with those cost measures that we've reviewed today. But for 2020, it would be worth looking into these BPCI APMs because, not only does it take you out of worrying specifically about the cost measures, it puts you into an advanced alternative payment model under the quality payment program, and that gives you an automatic 5% lump sum incentive bonus instead of waiting to see what percentage you get under MIPS that's going to get applied to your fee schedule. So, we strongly recommend that people move into APMs when those APMs are available to them to do. In the state of Maryland, we don't have access to BPCI Advanced. However, the HSCRC Maryland entity that has the waiver for Medicare will be introducing a number of ECIP, they're calling them, Episode Care Improvement Programs. The enrollment for that will be starting shortly. It's usually a short enrollment window, but that will happen through the summer. And many hospitals in the state are electing to participate in that and offer those as bundled payment options, and those also count as advanced alternative payment models. So if you were in Maryland, you could go out and look up ECIP, Episode Care Improvement Program, ECIP under the HSCRC, and that would give you more information on those. If you would like to talk with your practice advisor about it, certainly reach out to your practice advisor and they would be able to hook you up with that information.
And the next question was asked if the presentation will be available to print after the webinar. And it is available now under handouts, and they'll keep the line open for you to download that a few minutes after the webinar ends shortly.
I think that you can probably see my screen. This is where Barb was talking about going to QPP and looking up your cost measure information forms. So you say I want 2019 MIPS cost all, and it just gives you whatever you need. There's the information sheets like the measure specifications. You click on that, it would download it for you, and you can read all the specifications for each of the measures so that you can understand if you are billing these codes, and therefore will have cost calculated for you. Barb, I don't think that like last year they gave on the feedback reports what your cost, your
Right.
TPCC or your MSPB, the two overall costs, what they would have been if they would have counted them. Are they planning on doing that, do you think, for the episode?
I think the episodes are considered this year.
Okay, they're considered in 19. Okay, but would they be on the 2018 report? Like those reports they can see right now?
They will be on the 2018 reports.
Oh, okay.
Yeah, so if they're doing these procedures, they should be able to see
right.
How they're doing.
So if you look at your 2018 feedback report, the one you can see now, if one of these measures applied to you, it should be calculated at the end of that report with a note that says, we're just telling you these
Right.
ones and we're not really counting them. Yeah. All right, cool.
There were no further questions or chat comments at this time.
Okay. Well, I thank everybody for attending. Please take a look in your inbox for the invite to our quality conference call, which will be all about alternative payment models, and that's going to happen July 18th. We look forward to all of you being on the line, and we also are planning an event for later in the summer to talk about transitioning out of this grant, the TCPI, Transforming Clinical Practice Initiative, into support with other programs sponsored by CMS. So thanks, everybody. Have a great week.